Coming. We'll do the official opening since we've already been talking, but since it's now recording. Thank you for coming to case review tonight. We have a new format, which I wanted to I thought I'd test it out myself and go that way. It's more like a discharge summary kind of thing, where just to kind of get a little bit more medical, kind of past medical history and things like that, and then but still answers all the same questions that we covered with the last case review and so forth. First of all, I wanted to declare this as a safe space for everybody. We all come from different backgrounds, but we come with the intention of not trying to hurt people's feelings and things, but just want to declare that, and we will work through this as best we can. Also doing the land acknowledgement. We all live in the unceded lands of the previous Native Americans and like to wish, think about their past, their present, and their future, and wish their leaders and people the best. But I'll let you realize whose land you live on, because we all live on different lands. So,
Pomo.
Pardon?
Pomo.
Pomo. Okay.
I live on Pomo land.
Pomo land. Okay.
Umatilla, actually.
Okay. Well, tonight's case, I'll be presenting just because I figured if I'm going to change the thing up on everybody, I would probably be the first one to run through this just to kind of get through some of these things. So the reason for the reason for advocacy is that they needed help with the patient decompensating after a long hospitalization and a recent move to an LTAC. We used to say who offered the referral. I think, Cheryl, you got the call from Bannister and then said, no, this needs probably SEMA or I because it needs a doctor because they were really crumping. And so I got a call from Bannister, and that's how this all happened. So just to put that out there. So the history of present illness, or just past history of this, the client is a 27-year-old female with Turner syndrome who presented to the emergency room in Mississippi with nausea, vomiting, abdominal pain, hiccups for 2 months prior to the 2 months prior to this presentation. So at this time, she was diagnosed. She underwent a CT scan because the things just weren't working right, and was diagnosed with stage 4 ovarian cancer. She underwent tumor burden reduction surgery, and then underwent 1 cycle of etoposide cisplatin and bleomycin before leaving Mississippi. She left Mississippi because her husband was in the Army and was transferred to this area, and decided to drive across without just take this slow drive out here after getting the triple therapy for her chemotherapy. She underwent 4 further cycles once she arrived locally. She then developed acute nausea, vomiting, abdominal pain once again, and was taken to the local emergency room where she was found to be pancytopenic. And her numbers are quite extensive, or quite impressive. Her white blood cell count was 0.4. Her hemoglobin was 5.7. Her hematocrit was 17, and her platelets were 33,000. Which is, oh my God, kind of scary. Platelets under 50,000, you're at high risk for bleeding internally. White blood cell count under 2, you're extremely neutropenic and a risk of every kind of infection. And a normal hematocrit for a 27-year-old, for people that don't know, is somewhere between 33 and 35 for most menstruating women. Although with Turner syndrome, that might not have been the case with her. So she underwent a CT scan in the local ER here in Washington, which showed increased tumor burden with a clot with active bleeding. In the emergency room, she received blood product resuscitation and then acutely decompensated with a distended abdomen and hypoxia. She underwent emergent intubation and was taken for an emergent exploratory laparotomy, where it showed a 26-centimeter hemorrhagic mass attached to the small and large intestine. This was then removed. However, prior to closing the patient's abdominal wall, she coded and underwent a pulseless electronic Alternans code, which primarily happens because of lack of fluid. So she essentially didn't have enough blood volume. She was revived and then taken to the emergency room, and her abdominal wound was left open. She further developed ARDS postcode, and 1 week later developed encephalopathy, which was later determined to be a thalamic stroke. Also, at the time of the stroke, she developed something called Takasobo syndrome, which is also known as broken heart syndrome. Usually, originally was diagnosed with neurologic events where the left ventricle balloons out into just a big balloon at the end and doesn't work. And her ejection fraction at that time was 17%. This completely resolved as it normally does within about 3 weeks of her being in the hospital with therapy for it. Her abdominal wound was finally closed with removal of 14 centimeters of her jejunum. She then, after that closure, developed Staph aureus pneumonia, was treated with antibiotics, and was weaned off of, I'm sorry, not weaned, but was then underwent a tracheotomy where she had a trach placed. They then were getting her ready to transfer to the LTAC, but 1 week prior to that, she developed a right internal jugular blood clot. So it was then started on blood thinners. They felt that she did not meet inpatient rehab, and so was then transferred to LTAC off of the vent just on a trach collar on room air at that time. So that's kind of what happened before kind of during her initial hospitalization. After 2 days at the LTAC, the client was placed back on the vent, was diagnosed with Staph aureus pneumonia. Medical staff was not telling the family what had occurred, and they only found out when they went in and when the client was not answering her phone. And the nurse explained to her husband that she was back on the ventilator. So this is where I was brought on board at this time. Her past medical history, she has Turner syndrome, which she was on oral birth control. I just want to know if everybody knows what Turner syndrome is. Just, I don't want to, nope. Okay, so Turner syndrome, and Seema, you can correct me if I'm wrong, but my understanding of Turner syndrome is you have the normal 46 chromosomes, but you have only one X chromosome. You don't have two. So it develops, and they tend to have the classic diagnosis, or at least if you look in a textbook, is they tend to have a shield chest. They tend to be a webbed neck, but otherwise normal. But they tend to have other medical complications that happen to them because of the lack of the one X chromosome. The other past medical is just a stage 4 ovarian cancer, which she was diagnosed prior to moving to Washington. Past surgical, she had a port placed in Mississippi before she left, just for her chemotherapy. Medications that she was on when I first got on there was MS-Contin, antibiotics, and Eliquist. She was on UNICEF at the time. No allergies. Social history, she was married, recently moved from Mississippi because her husband's in the Navy, as I mentioned. She also has custody of her 16-year-old special needs brother. Her in-laws lived in the area, and her mom, during the second week of her hospitalization at the local hospital, moved here and permanently developed residency here in Washington from Mississippi, even though the client had control of the special needs brother. So that's what happened. So just kind of advocacy course. So the first day after I was brought on, I went down and saw the husband and the client at the LTAC. She was septic. She was on 100% FiO2. We spoke with the doctors at the LTAC about transferring her back to the hospital, and they refused. Serendipitously or horribly, during the discussion, the patient started having blood coming out of her NG tube, and it was in the container. She was actively bleeding at that time. The doctor's comment at that time was, well, she's going to die because she has stage 4 ovarian cancer. But it was like, okay, she's 27 too, and we can't just give up on her. The LTAC staff was pushing for comfort care measures, which could be a case in some places, but it's kind of hard on the first day of the job to actually kind of do that with people. And that, so but we kept pushing. Later that day, I actually got to speak with the patient's gyne-oncologist doctor, because as I was saying, with Turner syndrome, there are different things that happen with them. And what we found out with talking to our gyne-oncologist is that she actually had a germ cell ovarian cancer, which is very treatable. They felt that she had a greater than 90% survival with just the simple course of therapy that she had had. But definitely some of her, the cause of her medical problems with the pancytopenia and things was because of the chemotherapy, but they gave her a very high chance of surviving. And it's not the typical ovarian cancer that the LTAC doctors were thinking, or most of us think about, because unfortunately, if it is stage 4, the chances of surviving that are very little. And then after several days of going back and forth with the team at the LTAC, her pneumonia was treated once again, her GI bleed was treated, and so we ended up getting the gyne-oncologist to help us transfer her back to the original hospital that she was at. So she was transferred out of the LTAC, taken back because of everything that was going on. Which was a feat within itself, because most hospitals don't want to take them back after they send them. So she again was treated for pneumonia. The pneumonia cleared. Her GI bleed was taken care of. She started back on PTOT, but the patient was not interested in doing her PTOT. I mean, at this point, we're talking 6 weeks in the hospital, and just was not engaging in her care. She also was not doing the breathing exercises with the incentive spirometers to help try to get her off of the ventilator and back on a trach collar once again. And then, unfortunately, 2 weeks and 2 days after returning back to the hospital, she developed Staph aureus pneumonia once again. And it seemed like there was a cycle. About every 2 weeks, she would develop, 2 weeks after being taken off the antibiotics, she would develop Staph aureus pneumonia once again. At this time, we talked with the ICU team, and with the patient not engaging in therapy, the ICU team was actually saying, we have kind of 3 choices. We have comfort care measures, we have aggressive, 2 choices: comfort care measures or aggressive treatment. And so we took the family out, and I sat with the doctor and spoke with the client and said, what do you want to do? Do you want to just give up because she really wasn't participating in the PTOT, wasn't participating in respiratory therapy and all of that? Or do you want to do aggressive therapy? And she seemed despondent at the time. So we decided to kind of shelf that discussion and get psychology or psychiatry on board, just to see if they can evaluate her, because she was on no medications for depression. And I could only imagine being in the hospital, off and on vents, being sick, having surgeries multiple times, that depression is a normal thing that people could develop. So psych came by, saw her, found her to be clinically severely depressed, started her on antidepressant medicines. And then at that time, the ICU doctor also decided that this is a little weird that she keeps developing Staph aureus. And it was methicillin non-resistant, so it was not MRSA. But it was just kind of strange that it kept coming back within a certain pattern. So they ended up doing a laparoscopic thoracotomy, where they go in and take a look at the lung after a CT scan showed there was possibly some thickening in the pleural space, and found that she actually had empyema and not pneumonia, and that she just kept kind of reinfecting herself because the original infection was not treated. And so they treated her for actually 3 weeks of IV antibiotics, and that was cleared. Also, after about 3 to 4 weeks of the antibiotics, she started engaging again after being on the antidepressants, and where she was actually doing PT, she was doing OT, she was doing the incentive spirometer, and was, excuse me, fully engaged in her therapy to the point where they got her off onto a trach collar. And the repeat CT scan showed that the empyema had completely resolved. She was fully expanding her lungs, and she was up walking around the unit. So at that point in time, she actually was then discharged to home, which was amazing if you think of where we started, coming in and crashing and coding in the ER after resuscitation and everything. So I'm going to stop there and just see if people have questions about what all happened, just because I know it's a lot of information. And I apologize, but that's kind of just how some discharge summaries read. They just kind of boom, 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 boom. So does anybody have any questions for me for this, or you can just talk out loud? It's fine. We got a small group here that we can see everybody.
I have questions.
Okay.
So my first question is, was the empyema drained?
It was. They did that through the laparoscopic
Okay.
the video
And
system.
and when was she, I mean, what hospital was she in?
She was at the University Hospital.
Okay. And what LTAC was she in?
Well, there's only one in Seattle. So,
Oh, wow. Wow.
and I'll just leave it at that. I don't
Yeah,
want to.
my favorite, not.
Yeah.
And what else was that? Oh, so when she had that 26 centimeter tumor after the fact, was that concurrent with her original germ cell ovarian?
No, it was actually what came back. It took quite a while to come back. And actually, what it ended up being was more just thrombin, clot, and platelets and white blood cell, or what few white blood cells they had.
Oh, wow.
They went back and during that found none of the original lesions, none of the original lymphadenopathy was that had completely resolved after the 5 therapies of the triple therapy of the etoposide, cisplatin, and bleomycin. So they actually deemed her as being 100% clean at that time.
Wow.
They can't call it a cure because they have to wait for 5 years, of course.
Wow.
But I mean, it was one of those things that I remembered that Turner's had weird kind of cancers that happened with them, and it just happened to be this one, but no one was really thinking about that. And we didn't have the information from Mississippi, at least in the hospital records. The gyn-onc had them, but they weren't in the same system for some reason. So everybody thought she just had stage 4 ovarian cancer. So.
Chris, I'm curious how the LTAC received you.
Not very well.
Well, that's, I mean, aside from like the medical complexity, I will no longer take clients there based on a previous experience. So,
I mean, I have to say the ICU doctor for the LTAC was very much, how do I put this? A prima donna, I guess is probably the polite way of putting it. The one that was in charge of the floor was very understanding, but his hands were tied kind of because he was outranked by the ICU doctor per se. I think there was a hierarchy. But ultimately, what I got was the floor doctor to agree to write the transfer order, even though the university had accepted they weren't going to transfer her, even though the university said they were. And I was like, look, if this was your daughter, and he had a daughter of 27, what would you do? And he's like, fine, I'll sign the order. And so you almost had to kind of guilt him into it, which I feel bad a little bit, not much. But it's one of those things, you do what's best for the patient. And, in the end, with the patient being treated for depression, it's exactly what she wanted too, which I think is, the biggest thing. So I think,
Yeah,
yeah, go ahead.
no, I was just going to say, I mean, we have a dearth of LTACs, unfortunately. And so, but I've had really miserable experiences with them also. And so how long ago was this?
This was April of this year.
Okay. So, and she's doing okay now?
I actually called her last week to check in, and she's out doing normal stuff, taking care of her 16 or 17-year-old brother now. He turned 17 last month. There's still some family dynamics, which I didn't get into because the in-laws thought that their son was being taken advantage of with the whole family, including the mother moving up here from Mississippi, and I'm like, that's not my job. That's not. We're not getting in there. You can talk to a family therapist. That's not me. But no, I mean, but yeah, she's doing great. She's back doing usual things there. She's really excited because she actually has hair now because she lost all of it with the therapy and everything, and she was, a very attractive person, and it's nice to see her back doing that stuff. So
So
the
I'm
last little part
curious.
of the,
Oh,
I'm sorry, go ahead. Go ahead, Deidre.
I'm just kind of curious because I have a fear of taking patients or clients, so to speak, when they're already going through that. But if I'm sitting here thinking that, my goodness, if you hadn't jumped in there, she wouldn't be with us today, right? So my question is, how did you onboard her? How did you go in, and did you have her sign the HIPAA releases? How did you do that? And then for them to,
So I did it through her husband because she was intubated, sedated, and critically ill. So from my understanding of getting consent, or at least my interpretation of the law, and we can interpret it many different ways, but I took it as her power of attorney would be good enough to sign that for me, and that's legally her husband. So I did that, and so everything was done initially through him. And then when she got better enough and was able to respond, and she still had the trach collar or still trached, we had her writing things on a whiteboard. So we confirmed that she was okay with me working and that stuff. So, but that was a couple weeks afterwards. So things that just lesson learned is kind of the last little thing. One is if the patient's able to, always keep them in the loop and informed, which I think is a great thing. You always want to, I think as advocates and even as doctors and nurses and everything, we need to remember that we only should do what the patient wants. I mean, if they really don't want to be treated, that's their choice. Even if we think they should be treated, we can't force our views on them because that's nothing. But we always need to ask what they want and what to do. Second lesson learned is always dig deeper because we didn't know what type of ovarian cancer she had, and that made the big difference. And it was a very curious, very curable type. And also with the recurrent pneumonias, we always need to dig deeper. Is there more going on? Always ask the questions. Is like, why is this happening? Things like that. You don't have to tell the doctors that they're not doing something or their staff is unclean because she's getting Staph aureus, but something has to be going on that's different. And then I think people with long stays or long recoveries, never be afraid to ask for a psych evaluation. That also made a very big difference because she actually started engaging with the treatment and the therapies and things, which ultimately got her out of the hospital and got her where she is today. She is also off the antidepressants right now because it was a situational depressant, which is good. She was on them for about 2 months after she got out of the hospital and was able to come off them and no recurrence. And I think also with people with previous stroke history, especially during the hospitalization, that can be something that can happen more often because there's trauma done. And if you don't like the care that your client's getting, push. You just, and then my last comment that I wrote was never get involved in family drama, but I already mentioned that. So yeah, so that's the case. But I just I like these to be more of a kind of an interaction and talking, and if people have other things that they want to talk about or things of that nature, that was kind of the case. It was very hard and very draining. Kind of had to take a week off after that one just to kind of get your mind
Yeah,
back and
but
everything.
oh my goodness, yay! Oh my goodness, you just woo, because it could have been so much worse without a patient advocate. Because these, especially you guys don't have many choices. I find that very crazy. Just one LTAC.
For
Oh
the
my
city of Seattle,
gosh!
there's just one. And
Wow.
if you go to the eastern part of the state, I'm sure there's less.
I
Yeah.
had a family friend who's elderly and she has stage 4 terminal esophageal cancer. And one I was just so angry because she was hospitalized and she ended up getting an infection because they didn't turn her enough in the bed because the hospital who's I'm not going to say the organization's name, but they didn't have the staffing. There's, they're short staffed and everything, whatever the case may be, she got an infection. And then they had like the social worker come in and talk to her about hospice. And I'm like, sit down. She has a treatable infection. That's what we're here about. We can talk about hospice later. Like this infection is not going to kill her. Her cancer may be something that will kill her eventually, but right now we need like to focus on this infection. So it did strike me how like when it's like stage 4 cancer, people, even medical people can jump to assumptions that are not good. And so it's really up to us to kind of be that voice.
Yeah. No, I think, I mean, if that was found that that person you're talking about had like osteomyelitis or, infection in the bone and it creeped into and all that stuff, then you could start talking about hospice, I think, because then it's a much longer course and there's a high chance that possibly they could die from the infection. But if
Yeah,
it's just a superficial skin infection,
it was
you
like
do it.
bed
I mean, even
sores.
with palliative care, you're doing it for comfort,
Right.
um, and things like that. So I think it's totally reasonable. But you're right. People do jump to conclusions and not just because of the type or just but the stage and things like that.
Stage and yeah. And they hear the word cancer sometimes and assume they know. Like I heard when you said ovarian cancer, I was like, oh shit.
Well, I kind of specifically did it that way just to kind of get you the same way everybody else did. To be honest, I mean, just to be honest, I'll be that way. But I
Yeah,
wanted to have the same exact response because when we got to the LTAC, I went through the records there and they just had ovarian cancer. They didn't say what it
yeah.
was or anything like that. And so they were going with that assumption. So that's why I
Not
kind of
all
presented it
cancers
that
are
way.
the same.
Yeah, they're not.
Yeah.
So, yeah, I had a very rare, like, good kind of lung cancer. So, if you hear lung cancer, like, everyone freaks out because it's the deadliest cancer. But the kind I had isn't really lung cancer. It's like cancer that's in the lung, but not lung cancer.
Oh, okay.
So, it was a lung net. And so it's curable by surgery alone. And
Oh,
so, again,
okay.
it's another one of those things where it's like it freaks everyone out to hear it, but it's like, nope, not that kind. It's not the same.
I would just say with the, I mean, we always want to avoid LTACs if we can, but given the current LTAC, because there used to be like 3 or 4 in the Seattle area, and now there's just the one, and that's for the entire state. There's only one. As a clinician and as an advocate, when people are hospitalized, I think it's like all the more reason to like push for, really excellent care. So hopefully that can be avoided. So pushing people to mobilize, to get just to avoid complications of bed rest, the pressure sores, and pneumonias, and everything we can to keep them out of there.
Yeah, I mean,
Okay, I got a question.
yeah, go ahead, Deidre.
How big is Seattle? I mean, what's the population?
Our metro area, I think, is about 1 million.
And I'm just trying to wrap my little brain around this. Yeah. So I'm gonna say hats off to you guys because I thought that we had it bad here in Texas because we have about 5 or 6 just right here in the little bitty community area. So I'm just amazed because we are like fighting LTACs and everybody's short staffed. But when we have choices here, and I feel sorry for you guys because wow, when you are restricted like that, you only got one that you can choose from. And oh my gosh, here in Dallas Fort Worth, we have hundreds. It's like,
Well, I mean, the thing is with LTACs, it seems there's basically two corporations that own, I think, the vast majority of LTACs in the United States. So, for example, this one used to have a second location in Seattle, but it's the same organization.
mhm,
One facility was better than the other, and then they consolidated. But the LTACs are generally, corporate owned, for profit,
mhm,
um,
mhm, mhm.
and yeah, it's not great.
Goodness. Okay. Wow.
Yes, Ray.
So my experience is not so much how many are there, but how good they are. And it is so discouraging that these places, LTACs and SNFs, are just terrible. I'm just having a situation right now with a client who I placed after hospitalization, after surgery, at a skilled nursing facility. And this was supposed to be, this is acute rehab. I mean, not for a length of time. Was supposed to be the best of the best in the Los Angeles area. And I cannot tell you how many horrible things happened in that place. She ended up back in the hospital and now is absolutely not going to go back to a SNF. And I'm encouraging her not to. Unfortunately, she can't afford to have private home care at home, and she's all alone. So she's going to have to really be dealing with the whatever home health can provide for her, which is not totally enough. But the situation with skilled nursing facilities and rehab facilities is just abominable. There's just not enough staff. People were falling out of beds. No staff was coming when they were pushing their call buttons, and this was supposed to be like one of the best ones. So it's not the number; it's the quality. And I think the main problem is the staffing. There's just not enough people who are helping the residents and the patients in these places.
Yeah, I totally agree. But even though we have a great number here, what I'm saying is that if I only have one place to choose from, and just because we have a lot doesn't mean they're good. They're horrible. They're horrible.
Yeah.
Borderline lawsuit. And but my heart goes out to you guys in Seattle because you don't have choices. At least we have choices because I pulled one of my clients out of one. I walked in and I did not like what I saw, did not like what I didn't see. And I immediately went down the road and investigated another one that I'm a friend of or a network with. And you guys have any rooms? Give me a tour. Look, what's your nursing staff patient ratio? What kind of therapy services you do? All that. And we moved him, arranged transportation, and moved him from that sorry ass LTAC and into another one.
You're a force to be reckoned with, Deidre. I wouldn't want to mess with you. But no, I think it's come down to the point where I think, and this is part of the problem in the medical system right now, is that everybody's looking for their piece of the pie of what medicine has in terms of money. With these for-profits, they look more at their profits, not the patients, not their staff, not anything of that nature. And they wonder why they can't get enough people to hire on. Well, if you treat them the way they do, they don't pay them as much as they should, all that stuff. well, you're going to get people to look for someplace else. There are other reasons, we can get into that part, but I think part of it is just the for-profit nature of it. And not that you shouldn't make money, but we're talking about people's lives. And I think that's just a slight bit different than, all the other stuff out there trying to make money. So I don't know.
So the previous LTAC I thought was pretty good, the one that closed, but they closed because they couldn't make money. At least that's what they said. So who knows? Snoqualmie Hospital, I think it's called, is a swing bed hospital. So I've had someone there, as an LTAC patient, but they don't have that many beds, so it's not that easy to get people in there. And I had a pretty good experience there. The other thing I was going to say is that, so 26 or 7-year-olds, however old she was, almost never get the regular garden variety type of ovarian cancer. That's incredibly rare. Like, I don't want to say, I'm a gynecologist, okay, so I don't want to say I've never seen it, but I can't remember ever seeing it. So, it's just really, like, if you look it up to date, the epidemiology, you'd see, oh, no one gets this. What else could she have? So, so I can't believe that the LTAC, didn't, of course, they're not going to question whatever, but, you're considering putting someone on comfort care, it might help to find out what they had.
Yeah.
Just a thought.
You're 100% right there, Seema. I mean, that was kind of the scary part about it when you walk in and you have this kind of like, whatever, people die. It's like, yeah, but this is 27-year-old. I mean, we can all have the thing of, you're 97 or 87. Should we expend all the money and resources and things? Okay, we could have the discussion, but at 27, I think you go the full 9 yards, just to give them a good chance at least having some experience of life. But who am I? But yeah.
And
But I was
sorry.
No, go ahead. Go ahead.
I am going to shift gears a little bit. It's so fortunate that she agreed to talk to a psychiatrist and go on medication, because unfortunately so many people don't. And clearly it made a huge difference in her recovery. So what would have been your strategy if she didn't want to talk to a psychiatrist or take medication when she was severely clinically depressed?
I mean, you can lead a horse to water, but you can't make him drink. I mean, that's just the way it is.
Slip it in her applesauce.
You can do that at the VA. I don't know if you can do it at the university hospital. But no, I think, it would have been kind of a daily conversation with her and her husband, and had her husband kind of, I talked first with the husband to talk about, look, I think that she's clinically depressed. I think this is just situational. This is something that's not lifelong or permanent. And that she just needs something to kind of kickstart her back to, given everything that happened. So he was on board. So getting him on board and getting him talking, because he was there pretty much 24/7, just talking to her, that it was nice that she agreed. And if she hadn't, I honestly don't know what we would have done. I mean, it probably would be a different outcome. I mean, to be honest with you, it just, because you can't force people to take medications that they're refusing, or even talk to people that they want to, because she was refusing the PTOT, was just to get her to walk around even. So you're kind of stuck with your hands tied behind your back.
Wow, did you have a lot of conversations with the husband too? Because I bet you he needed some help handling and coping with everything.
I did. He was a really neat guy. He is your stereotypical corporal in the Navy,
Mm.
if you've ever met Navy guys. He also was a chef for the Navy and talked about how when he went to a certain port, he always got arrested. And I'm like, oh gosh, you're like my younger brothers when they're in high school kind of thing. But he was a really nice guy, really good. His family was interesting. His mom actually wrote a book and talks about him and his upbringing in this book. Because she was a force to be, I mean, she is a CEO of a large company and things like that. And so that was, my heart went out to him because there was a lot of family drama. I'll just leave it at that. But, you know, you treat him the way you can, you give him the information, you kind of pat him on the back and encourage him, and that's the most you can do. So does anybody else have any questions? I mean, we can keep this shorter and give you guys some time back with this beautiful sunshine and all that stuff, even though it's hot.
The other thing about LTACs here is that, like, I can't remember exactly where they are, but there's one like maybe in Idaho and Oregon, like Northern Oregon. I can't remember because it's been a while since I looked. And I have, considered sending people to those, ended up not needing to, but, it sounds onerous because it's not right in town. But, if they're going to get hideous care, then sometimes it's maybe the better thing to do.
The other option that have done, I had two other clients since that time where we just basically refused to send anybody to the nursing home or the LTAC because it wasn't it wasn't a good fit or whatever. And with that refusal, the hospital ended up keeping them until they finished their rehab, which unfortunately puts a strain on the hospital a different way because there's one less bed, but the client and patient actually get the proper therapy to a point. I mean, you can't drag it on too long, but like one of the clients I had that I did that with was not able to weight bear because they had a fractured pelvis. They were in a car accident. And they couldn't weight bear, and they were going to send her to a nursing home to do that. But luckily she had a roommate who was traveling 90% of the time, wasn't home, so she was living alone. No family around and things like that. So we made a case that she couldn't go there because they didn't accept her insurance, which was Medicare, which helped. But then just make a case like, look, you can get her to a point where she can go home and have like a visiting nurse. That's approved by Medicare. We'll do that, but otherwise she's not being transferred. And they balked, but they backed down. So that's another option.
Mm-hmm. So, I'm a PT and I work a tiny bit at a hospital. And we have a whole unit of people who are not leaving the hospital for any number of reasons. But the hospital does not staff the therapy department to cover that unit. So at least at that location, the rehab in place is what we call it, does not work very well. And I think, if they are at a SNF, they have to get their therapy. That's how the SNF gets, part of how they get reimbursed. So it's a catch-22.
No, you're right. But if they're not accepting of the person's insurance, that you can make a difference that, I mean, can they afford it just to pay out of pocket? It's probably what, $2,000 a day would be my guess, or something insane. But yeah, if they accept the insurance, I mean, I can see that. But there's certain times I think it's reasonable, but most of the time then if it's that way, then you kind of have to lean on the family to bring in the troops to help.
Yeah, there was no other accepting SNF.
Now this was in small town in eastern Oregon, so they only had one sniff,
Ah.
and so it was a little different that way.
Yeah,
So-
yeah. On the topic of LTACs, I had someone contact me sometime back, and their person was in a hospital after a trauma, and the recommendation was LTAC. And this guy was out of state, but he's from Seattle, so we were like talking about that, and I was just like, well, you don't want to go there. And basic, and so we're like talking about all this stuff and researching, and it's like, well, yeah, there's these two companies and they own everything. And then she said, well, where would Bill Gates go? And I was like, well, that's an interesting thought. I mean, he could just set up an LTAC in his home, but so I did start searching, and like there are hospitals that have like the VIP units and stuff like that. And so I was finding some things in that kind of realm. And although these people were well resourced, they were sort of well resourced as far as like normal people go, and not like Bill Gates. And they didn't end up signing on, so I don't know what happened with them. But anyway, there are luxury places out there.
Well, there are at everyone, because I know when I interviewed at UCLA for my internal medicine residency, we couldn't go up to the 5th floor because there was a sheik and his family that had basically rented out the entire floor.
Yep.
So I was like, okay, we're not going to show you that floor today. And I'm like, I understand.
Yeah. My mom was hospitalized in Palm Springs, and the hospital there had a whole unit.
Wing for the stars, probably.
Yeah, it was funny. Her doctor was like, God, I hate going over there.
Oh, well.
Well, Chris, I'm so glad you helped them out.
Yeah, I mean, it's one of those, I mean, it could have gone multiple different ways, but it's nice that she's still alive and kicking. So that's the reward right there. So
Heck yeah.
So do you, I know you said you called them a week ago or was it the other day? So did she go back to Mississippi or is she staying there?
she's staying here. Her husband was transferred by the Navy to here. He originally was supposed to be transferred to Tokyo, but because she got the diagnosis in Mississippi, they canceled that and gave him a choice of either north of Seattle or Portland. And he chose north of Seattle because his family lives here in Seattle. So it was a good choice for him because he actually was able to his family live close to the University Hospital where she was most of the time, and just stay there instead of doing the hour and 10-minute drive / ferry to get back to the mainland and everything. So
my next question is do you do any services outside the hospital to keep her from going back to that god awful place? I don't.
I haven't because part of the family drama that I didn't get into is that the mother-in-law was the one paying, and she cut funds off. So I'll just leave it at that. But no, I've kept in contact with him just to check in, just to kind of be friendly, just to see how they're doing, and still answer questions for free because they were just nice kids. It kind of is what it is. But yeah, so I gave him a call. I gave him a call about a month after she got out of the hospital, just to make sure. That was after a month after I stopped working for them, and then just a couple weeks ago because I knew I was presenting this now, and just to kind of say all that stuff just for complete of the presentation. Does anybody else have any other questions? Alec, you've been kind of quiet. I can.
I don't know, I've been listening to everything. Makes great sense, and thank you for saving this person's life. That's all I have to say.
Okay. Not trying to pick on you. I just thought I'd ask.
Right. No, I understand.
As I said at the beginning, this is a safe place, so we're not.
Did the Turner syndrome have any impact on her medical condition and how she was able to pull through it?
My understanding, it was just the only impact it had was just the type of cancer that she had. But to be honest with you, I've read about Turner syndrome. She is actually the first one, even being practicing for 20 years, I've ever seen. So it's there are many different genetic makeups out there. I was just explaining this to my wife the other night, that you have Turner syndrome, then you have normal XX, XY, and then there's also X double Y and X triple Y, which unfortunately most of the double and triple Ys are incarcerated because they tend to have aggressive anger management issues. So it's just one of the strange genetic things that happened, and it's just, nothing is perfect when it comes to the body. Meiosis and mitosis, there are mistakes that happen. That's why cancers develop and things of that nature. So
Interesting, because I have a young relative with Turner syndrome, and
okay.
she's doing fine. She became a nurse. She's good at what she does, but there are a lot of from her childhood, a lot of different medical problems that came up. So
I just don't know, to be honest with you. I'll just be honest, just because I haven't seen many.
Right. But what's so awesome about these case reviews? One, I'm gonna ask everybody to spread the word about telling your buddies to come to these case reviews, because it gives a sense of we're all out here and we're in this together and we're learning as we grow. To be approached and to be honored to have these extravagant cases and to be able to have great outcomes, that says a lot. So, Chris, you are awesome. I love it. And if I encounter somebody, I'll be calling you or Marcy.
I'm not an expert. I will
But
stick
it
to
takes a team.
yeah. So, okay. Well, thank you all for coming. I guess I'll give you time back. We're at the hour. It could go to 6:30, but I think we've answered all the questions that everybody had and things. And I wish you all a pleasant evening, and we'll go from there. And if anybody has a case,
Yeah.
we're always open to have people present. This is a really benign way to present cases. So, no one yells and screams at you. So it's not like the grand rounds I used to do or the M&Ms I used to do. Those things were, oh God.
Oh my gosh.
So
I'm getting PTSD. Sorry.
Yeah, that was a good case. Thank you.
no problem. Thank you.
thank you.